Good night, everybody. Dr. Gilbert Tang is with us tonight. He is Associate Professor of Cardiovascular Surgery and Surgical Director of Structural Heart SEND Program at Mount Sinai Hospital in New York. He is what I call the surgeon of the new era. After a conventional training in cardiovascular surgery, he became also expert in transcatheter therapies. So he does transcatheter valves, TAVR, mitral clip, complex valve repair, open and endovascular aortic surgery, and transcatheter treatment of all structural heart disease. He's also involved in surgical innovation. So it's a pleasure for us to have you here. Please, Dr. Tang.
Thanks very much for your kind introduction, Professor, and my pleasure to welcome myself to Latin America and Brazil. The audience here, look forward to a very engaging discussion and perhaps some of the more controversial discussions as well. These are my disclosures. So I think in terms of what we are offering our patients in 2020, in terms of valve replacement, we have these options. We have mechanical valve still, we have tissue valve, and now with tissue valve, we have transcatheter aortic valve replacement, TAVR. We can still have conventional surgical valve replacement with tissue valves, and also the Ross procedure, which is an autograft replacement. Now, when do we choose a mechanical valve? People will say mechanical valve is obsolete, but I think we still have to look at patient preference. And of course, they have no contraindication to lifelong anticoagulation. Younger patients where valve durability or multiple reoperations can be concerned. So if the patient wants to avoid multiple reoperations because of tissue valve degeneration and they're concerned on durability, maybe a mechanical valve would be a reasonable option in such patients. But of course, we all know that reoperation, especially reoperation with only isolated AVR, is much safer now than before. So if you have a center of excellence or expertise in reoperation, perhaps tissue valve avoiding anticoagulation is a reasonable option. Now, when do we choose a tissue valve? Again, I think we always have to discuss with our patient on what their preference is, depending on their lifestyle, depending on what their needs are. And of course, if they have contraindication to anticoagulation, it's very reasonable to choose a tissue valve despite a younger age. And we all know that tissue valve, no matter what type of tissue valve, has limited durability. So especially younger patients, they need to know that they are likely to need to have re-intervention in the future. And of course, ideally, we would like to minimize the number of open surgeries in their lifetime. Just like a pediatric patients, they often require multiple surgeries because the prosthesis fail when they're young. But now they have transcatheter options, so maybe we can mix the two to avoid regular open heart surgeries in the future. Now, how do we pick which tissue valve? We talked about a number of different tissue valves. So I think the importance to know is, number one is, what is the pathology? Is it aortic stenosis or regurgitation or mixed disease? Are these patients younger or older? What is the anatomy? And this is something very important in terms of imaging. So are they straightforward from a TAVR standpoint, or is it going to be a problem in terms of the anatomy being hostile to TAVR? And then we looked at the surgical risk. Is this a low-risk patient, intermediate, high, or extreme risk, as we have defined in the United States? And also, what is the durability of the prosthesis for this particular patient? And what are the re-intervention options if whatever prosthesis we put in will fail? And finally, what is the patient preference? Do they want less invasive now and more invasive later, or vice versa? Here's a spectrum of patients now for TAVR indicated in all risk categories. So from low all the way to extreme risk. Surgery still have a role in low and intermediate risk patients, but certainly if the patient prefers and the anatomy is suitable, TAVR is an option for all these patients now in the United States. There are some trade-offs between surgery and TAVR. You can see here. Surgery has less paravalvular leak, has less conduction system and pacemaker need. TAVR has lower incidence of new AFib, less bleeding, less renal injury, of course, faster recovery and shorter hospital stay. But coronary access is certainly easier for after surgery. And we know, at least in terms of durability, surgery with the current valves have known durability longer than TAVR at this time. We know that new left bundle branch block is not a good thing after TAVR, and this has been shown in a recent meta-analysis showing that it increases all-cause mortality, cardiovascular mortality, rehospitalization, and increased pacemaker rate. So this is important from a younger patients and low-risk patients standpoint. We also shown that there are some anatomic risk factors for left bundle branch block after SAPIEN-free or Evolut TAVR. And one of the important aspects is implant depth. That's why we have certain techniques now to minimize the pacemaker rate or left bundle branch block by implanting a valve higher. And we oversize it less now to avoid conduction system disturbance. Pacemaker, we know that also can be a problem after TAVR. It reduces LV recovery and also possibly increase mortality and rehospitalization. There are a number of predictors associated with that. The right bundle branch block is a huge predictor. We also try to implant the valve higher now for TAVR to avoid pacemakers. Now, what about coronary access or redo TAVR after we put a TAVR in, let's say, in a younger patient? These are some of the factors that we ask to consider in terms of when we do the initial assessment on CT to look at these anatomies can be favorable for reintervention later on. And one of the concepts that we published is the commissure alignment after TAVR. In terms of the coronary access, we published a paper before in JACC looking at both anatomic factors and device and procedural factors in enabling coronary access. And this recent paper also looking at how many patients right now with failing TAVR needing a redo TAVR, and interestingly, the rate is very low, about 0.22%, and also the coronary obstruction rate is also very low. But keep in mind that this paper is highly selective. Patients who can do redo TAVR will likely be in this registry, and those who cannot do redo TAVR will probably have had surgery. So we know that this series is likely a very selected group. The reason why we know that is that if you look at these two anatomic studies, one is from our group, looking at even after SAPIEN-free TAVR, about 13 to 20% of patients are unlikely to have a redo TAVR. The reason being the anatomy is very tight for the redo TAVR. The SAPIEN-free valve you can see here with my arrow on my mouse is the valve goes all the way above the sinotubular junction, and there's really no room for coronary flow if you put a second valve inside. And this is also shown in a CT study from the MedStar Washington Hospital group in a low-risk study, in both published in JACC Intervention. So these patients, when they come back, unless there's new technology available, would likely require surgery to extract the TAVR valve and put a surgical valve in. Some people say, well, what we can do after surgical valve, or maybe even TAVR valve, we can do this basilica technique, where we split the leaflet that can cause the coronary obstruction, and then put a TAVI valve inside and solve the problem. Well, you can see here in these two figures, it may not solve the problem completely. The reason being is that we cannot achieve commissure alignment like we do with surgical valve. And you can see in these two examples here, if you have a commissural tap of the transcatheter valve facing the split portion of the leaflet, you can still obstruct the coronary and cause a fatal complication. So we still need to learn more about this and do a better job in getting commissure alignment, such that even if we try to do basilica, we can avoid coronary obstruction. And you can see here, this paper from JACC Imaging shows the problem of even if you can do redo TAVR, now you have two transcatheter valves in the same position in the aortic root, coronary access could be a problem because you now don't have much room for the coronary catheter to engage the coronary afterwards. So this is certainly a concern, I think, in younger patients or patients with moderate coronary disease that may require intervention down the road, because essentially you've created a lot of barriers like a Russian doll effect against the coronary ostium. I want to change the focus a little bit on a concept called prosthesis-patient mismatch, which essentially is when the orifice area of the valve that you put in is too small for the patient's body size and cardiac output requirements. And you can see here, the severe prosthesis-patient mismatch, PPM, is defined as 0.65 less than 0.65 centimeter square per body surface area meter square. That is equivalent to almost critical or severe aortic stenosis. If you think about the definition of severe AS, is 0.6 centimeter square per meter square, or less than 1 centimeter square. So this is equivalent to almost iatrogenic or functional aortic stenosis. Now, why is this important? Because now we are seeing patients with previous surgical valve replacement come back, refer for TAVR because they think the valve has degenerated because the gradient was very high. But when we look at the transesophageal echo or CT scan, the valve was completely normal, opens and closes perfectly. And what these patients actually experience, in our opinion, is actually severe PPM. They don't have valve degeneration. So doing a TAVR in these patients will not help them because they have existing PPM. And why is existing severe PPM important? Because you can see here, not only do they have less LV mass regression, they have less regression of MR, worse exercise capacity, more hospitalization, and more importantly, may accelerate the incidence of structural valve degeneration. Here are two examples of what happens when patients have PPM versus no PPM, and they're being evaluated for valve-in-valve TAVR. On the left side, you can see the patient has no existing PPM. So they had a surgery, and now the valve degenerate, they now have a high gradient. If you do a valve-in-valve TAVR, you should restore them back to the normal or near normal effective orifice area, so you will not have a problem afterwards. If you have pre-existing severe PPM, like in the right side of the graph, you can see here the gradient is already very high with a low index effective orifice area. When the valve fails, it gets worse. But when you do TAVR, if you don't do any kind of other tools or techniques, you're not going to fix the PPM, even though you fix the valve degeneration. So the patient will still not experience relief of their symptoms. This is a paper looking at 1-year results owing patients for TAVI or valve-in-valve TAVR. And you can see here, small patients' prosthesis and severe mismatch lead to higher residual gradient consistently after valve-in-valve TAVR. And here's another example of a case where you have severe PPM in a surgical valve. The patient was implanted over 10 years ago, had valve-in-valve beforehand has a valve area of 0.35. Even after valve-in-valve TAVR, you still have an index valve area of 0.48. So you essentially have not relieved the PPM. Versus this patient had no PPM before, after the SAVR, the valve degenerated because of an aortic insufficiency. You do a TAVR afterwards, you restore the AVA to 0.95. There's no mismatch. This patient will do very well clinically. And we know that in the VIVID registry, you can see the impact of PPM is that it leads to higher gradient and even higher 30-day or 1-year mortality. So you can see that severe PPM in the context of valve degeneration may need surgery rather than valve-in-valve TAVR. But we know that not everyone is a candidate for reoperation. So this group has published results that maybe some of the surgical valves can be fractured or cracked. And you can see this is a list of valves that can be cracked that are in green versus the valves that cannot be cracked, which are in red. So some of these valves can be cracked and open up. The valve dimensions are a little bit larger than the implanted size so that you can implant a larger TAVR valve in to avoid severe PPM. And this is a paper that shows how this is done. Use a high pressure balloon either before or after you implanted the TAVR valve, and to break the valve ring, because most of these are made of plastic. And you can see here, they can increase the orifice area and reduce and expand the size of the opening. Now, be careful though what you wish for. There are some complications associated with this technique, such as coronary obstruction, because the valve expands more now. You can have aortic root rupture. You can have acute AI causing hemodynamic collapse. You can actually injure the TAVR valve if your pressure is too high when you do the balloon inflation. And of course, if you're not careful, you can cause valve migration and embolization. So if you have severe PPM, how do you decide whether you do Reop surgery and not TAVR? Well, if you cannot fracture the valve to reduce the mismatch, you should consider reoperation. If you have high coronary obstruction risk and you cannot do the basilica technique, you should consider reoperation. And finally, we know that reoperation is not typically difficult to explant the surgical valves. We don't know about the TAVR valve, but certainly the surgical valves are pretty straightforward of removing them. Now, how do we know whether TAVR explant or explanting a TAVR valve is hard or easy? Well, this is a paper published from JTCVS looking at a series in Michigan on explanting a TAVR valve. You can see here, this valve has a lot of degeneration. This is, I believe, a sapien valve. And you can see, actually, no, it's an evolute valve because of high autotomy. You can see here it's quite degenerated, and they have to actually gently peel off the crown where the arrow is from the intima of the aorta to avoid an aortic dissection. So in terms of younger patients, I think that's really where the discussion is. The tissue valve option would be in TAVR if they have favorable anatomy for redo TAVR, and maybe if they cannot do redo TAVR, surgery may be a better first option, such that they can do a TAVR afterwards. And of course, another option that we have seldom discussed is the Ross procedure. Now, what is the Ross procedure? This is a state-of-the-art review. You can read that on your own leisure on Jack on this topic. Essentially, what they do for younger patients to avoid any kind of anticoagulation or valve degeneration, they use the patient's own pulmonic valve, flip it around and put it into the aortic position, and then reinforce the aortic root to make sure that the pulmonic valve in the aortic position can function with good durability. And then the pulmonic valve is replaced with a homograft, typically from a tissue bank. And you can see here, there are several studies, including randomized studies, showing that a Ross procedure with an autograft operation can have life expectancy at 12 years, matching the general population. You can see here the blue curve and the gray curve. And if you look at mechanical aortic valve replacement, which is typically done for these younger patients, compared to Ross procedure, you can see on the right side, there is a improved survival for the Ross procedure patients. And if you compare them again between mechanical valve, tissue valve, which is in gray, and the Ross procedure on the blue on the right figure on the D, again, the risk of valve degeneration is much, much lower for the Ross procedure. So in summary, I think if you have a surgeon who is an expert surgeon in Ross procedure, and we have a number of them in the world, you can certainly have the advantage of long-term survival. Good quality of life is like a native valve. There's no anticoagulation. There's low rate of valve degeneration. But of course, it is technically more complex in terms of surgery. There are two valves that can potentially fail. And of course, reoperating on these patients can be challenging. Having said that, on the pulmonic side, if that fails, it is a homograft. So you can certainly consider a transcatheter option. Now, what about bicuspid aortic valve? We know that bicuspid stenosis affects younger patients in general, and particularly younger patients. This is a JACC imaging classification looking at some of the patients being evaluated for TAVR, what their bicuspid anatomy looks like. And most of the time, they are considered what we call type 1 morphology, meaning that they have two commissures, but with a raphe, like a T shape of one of the cuts, that makes them potentially challenging for TAVR because the valve will not fully expand, or it may even have risk of rupture because the valve is typically much more calcified. You can see here the reason why TAVR can be challenging in these patients. In a trileaflet aortic valve, it's much easier to actually circularize the orifice of the trileaflet valve. You can see on the left side, versus if you look at a bicuspid valve, it's more like a fish mouth configuration, and it's much harder because the constraint of the raphe or from the anatomy with the calcium to make it in a circle after the TAVR is deployed. There are papers looking at TAVR in bicuspid valve, and you can see here this paper from 2-3 years ago looking at newer generation valves, that even though the success rate is better than the older generation valve, there's still risk of paravalvular leak, second valve implantation, and especially pacemaker implantation, which is not, again, benign, in the low risk or younger patients. We previously worked together on a JAMA paper on looking at the SAPIEN 3 in bicuspid aortic valve TAVR in the United States. And you can see here, pacemaker, again, is higher in the bicuspid population at 30 days and at 1 year. More importantly, there's also higher risk of stroke as well at 1 year time. So you can see that this is 30 days, I mean. So you can see that it's certainly still a concern in this cohort. Here's an example. This is a very heavily calcified bicuspid valve in a low-risk patient. You can see that's a very calcified raphe here at the base. So the circle indicates the calcium near the annulus. Well, there's only one way this calcium is going to go. It's going to go outward. And depending on how much radial force the valve provides and try to expand, it can go outside the heart. You can see as shown here with this potential risk. So here's the question we need to discuss as a heart team. Should we do a TAVR on this patient? If the patient refuses surgery, what are we going to do? So we decided here to consider doing a TAVR with a 29 SAPIEN 3. We took 2 cc out of the balloon because we worry about an annular rupture. But the question is, if you take volume out of the balloon, does it affect valve durability? Well, this patient ended up having a successful procedure, but developed aortic fistula from a contained rupture essentially. And what is the long-term impact of this fistula? And because the fistula formed, the conduction system now is damaged, the patient needed a pacemaker. Is this a good thing for the patient? So the patient went home in about 2-3 days, but you have these potential complications. And so what is the trade-off in doing TAVR in bicuspid valve in younger or low-risk patients? I think this is something that we all need to answer honestly and discuss this openly with our patients. I think we don't talk about aortic regurgitation because there are patients who have AI that are high risk for surgery that right now we don't have a lot of options to treat because unlike aortic stenosis, AI have no calcium present. And so the mechanism of anchor for TAVR is with calcium on the valve. This is a systematic review looking at pure AI with TAVR. And you can see here, even with the newer generation device, or the older generation device, the number of cases needing a second valve placement is quite high, and also conversion to surgery as well. And you can see here, this is the United States data, is that you can see that in terms of all-cause mortality is still quite significant at the initial 30 days. Now, these are high-risk patients for surgery, so the mortality rate would be expected relatively high. But you can see here, this is still something that we need to work on because not everyone may qualify. Now, what is this entity here? This is endocarditis, right? So you can see here, after endocarditis, there's really no transcatheter treatment to manage these kinds of patients. So surgery is the only option to explant the surgical valve after prosthesis, prosthetic endocarditis or native valve endocarditis. However, TAVR as well can have risk of endocarditis. You can see this is explanted SAPIEN 3 valve with endocarditis present, and you can see it's quite ugly. And the only way to fix this is surgery, and TAVR would not be possible in these patients because of the presence of ongoing infection and potential aortic root abscess. So in summary, I think TAVR is indicated in all surgical risk categories now. The high-risk anatomy for TAVR in lower intermediate risk patients may be considered for surgery as an alternative because surgery we know is very safe in these patients. With patients with severe PPM, we should consider Reop SAVR over valve-in-valve TAVR unless we can fracture the valve and we can expand the valve orifice area. And I think surgery might still be the default in younger patients, for example, Ross procedure, low-risk bicuspid patients, or patients with native AI or endocarditis where TAVR would likely be unfavorable. So I think in summary, there's a lot of opportunity for TAVR. I think it's a very excellent therapy for a lot of the patients. It's a very good complementary therapy to treat aortic valve disease, particularly aortic stenosis. But also surgery should still have a role. And I think heart team discussion is the key to manage these patients in a holistic manner. Thanks very much for your attention.
Thank you very much, Gilbert. Excellent presentation. Please, everyone, feel free to ask questions by the chat. As I'll start asking you some questions. You mentioned a very important issue, which is the PPM. Now everybody is more interested in trying to evaluate if there is really PPM or not. So when you do your first operation and you decide to do a surgical aortic valve replacement, what is the minimum size of the bioprosthesis that you use? Which access, minimally invasive or conventional sternotomy? And when do you enlarge the root in order to avoid patient prosthesis mismatch?
Yeah, no, that's a great question. So we know that from the data that TAVR has a larger effective orifices area than surgical valves in general, especially the supraannular self-expanding valve. So in patients with small aortic root, in native aortic stenosis, if you're going to have to put a small surgical valve and there is a risk of aortic root enlargement, maybe TAVR is a better option, at least initially, even though you might have to do reoperation later on. If you want to do surgical aortic valve replacement, we try to do now putting at least a 23 or larger valve in men and maybe a 21 or larger in women. It obviously depends on the body surface area of the patient. So you can have an obese female. You might need to enlarge the root to put a 23 at least to be able to implant. Current generation, the Inspiris valve now has a hitch point that may facilitate valve expansion to fit a larger TAVR valve inside, but we don't know that yet. We don't have the data on that yet. But that's currently an option in terms of the surgical prosthesis. In terms of the approach, it really depends on the comfort of the surgeon. Safety is number one. You can do a full stenotomy and be a very safe operation. The operative risk for elective isolated AVR now should be around 0. Should be really, no one should be dying from an elective isolated AVR operation. So if you are familiar with the right mini thoracotomy approach, by all means, that's an option. Mini stenotomy also is another option. So there are different options, but the surgeon needs to be very comfortable with the approach that they take to do that. Now, having said that, some of these options may be open to rapid deployment valves that one of the attendees is asking about. So rapid deployment valves certainly can minimize the cross-clamp time. However, you need to size the prosthesis properly, because if you oversize too much, you can stretch the root and kink the coronary. If you undersize, you can lead to paravalvular leak. If you don't debride the valve properly, you also may risk paravalvular leak, and there might be now some evidence of potentially higher pacemaker rate because of the sizing issue. So, if you have a rapid deployment mini AVR that would have complications similar to TAVR, then maybe TAVR is a better option, because at least that's less invasive, and the patient might go home the next day. So I think it's very important to make sure that you can do the operation safely and effectively. The root enlargement, I train in Toronto, so we do a lot of root enlargement. We don't do a very aggressive root enlargement. We prefer to do what we call mini NICS operation, which is also basically cutting down towards the annulus of the non-coronary sinus. We don't need to do any special patching in the left atrium. We never open up the left atrium. We just put a teardrop shaped patch to enlarge that area, and we run a double layer sutures from the bottom up, and then we implant typically a one size larger bioprosthesis there, and we can close the aorta maybe with a aortotomy, or we can have patch aortoplasty just to reduce the tension on the closure of the aortotomy. That usually works very well. We teach our residents how to do that kind of operation. So it's very, very reproducible.
Okay. Ana Paula is asking, in your opinion, is there in general any age of cutoff for TAVR? I think, Gilbert, this is a very important point, that patients usually, they want the less invasive approach, unless we can clarify that the results are not the same. And even if we explain it very well, sometimes they decide for the minimally invasive approach. So let's say you have a patient in their 60s, and it's not a bicuspid valve, it's a tricuspid valve. What would be your cutoff if the anatomy is good for TAVR and is a good candidate, low risk for SAVR?
Right. So, what we do is we give them all the data that we know. So we know the low risk randomized trials, the average age is in the 74. Right, so he is younger. The patient is younger than the average age in the trial. So we cannot use the trial results to apply to this particular patient. The second point is we know the durability of surgical bioprosthetic valve in this particular population, 65-year-old. We have long-term data on this. We don't have that for TAVR. The TAVR durability data that we know, 5 to 8 to even 10 years are the older age group, 80 plus years old, not even 75. So we have to tell the patient that either surgery or TAVR, the patient should need an aortic valve reintervention in the future, whatever that might be. And so having set that expectation, then we look at the CAT scan to look at what is feasible if we do surgery now versus if we do TAVR now. If we cannot do a redo TAVR in the future, depending on the anatomy, we have to let the patient know that the patient may likely need surgery in the future, no matter what the technology may be. And also, that's not even accounting for commissural misalignment with TAVR. If the patient anatomy is favorable for surgery now and valve-in-valve TAVR later, which we do now anyway, then we can let the patient know now that if you have surgery now, the bioprosthesis may last 10, maybe 15 years. Then they can do a TAVR later on, and that will probably last them a lifetime. I think that is something that we can discuss. I mean, no one has a crystal ball, and ultimately it's a patient preference. But I think now we routinely have this kind of discussion, and that can only happen after you look at the CAT scan to look at the anatomy of the aortic root, so you can have a very informed discussion.
Right. There are two questions regarding the paravalvular leak.
Yes.
Rodrigo and Renato. One asking if there's a place for percutaneous closure in the leak, depending on the valve, and the other one about TAVR and TAVR, that you showed that there are two groups in that paper. The first group that went reintervention between the implant and the first year, that they considered a valve failure, a procedure failure. And beyond 1 year, that is considered a structural valve degeneration. So do you think there is a role for TAVR and TAVR between the implantation and the first year, if there's a leak?
That's a great question. We have seen these patients at our clinic. So it depends what the mechanism is of the paravalvular leak. If it's due to under-expansion of the valve, then maybe a balloon post-dilatation may be reasonable to try to reduce the paravalvular leak. And if that is due to a hostile anatomy like calcium, we know that with the valve, the stent frame and the calcium is not going to seal. So if it's feasible, PVL closure might be a safer option, because if you post-dilate, you might end up having an annular rupture. So you really have to look at the anatomy very carefully. So you need to use angiography to localize the PVL. You need to look at TEE and the CT to try to see if it's anatomically feasible. So for example, in certain anatomy where there's not much space, crossing that PVL to try to localize that can be very difficult to wire. So it depends on the location of the PVL and how severe it is. So we have done both, and it depends on the mechanism of failure.
João Cavalcante is asking a very tough question. What is your management approach at Mount Sinai for a new left bundle branch block at post-TAVR?
Yeah, well, thank you, Yao, for listening to my presentation. Good to see you. And we saw recently this paper on Jack mentioned on actually using pacing the atrium as a way to interrogation for pacemaker. We don't do that routinely. So with new bundle branch block that is persistent, if there's no widening QRS complex that is of concern, we consult the EP colleagues. We would discharge them with an event monitor. Those with atrial fibrillation with difficult to control, rate control with new left bundle that we would risk potential heart block, we might be a little bit more proactive on putting a permanent pacemaker in. But we always consult our EP colleagues before doing anything. Majority of them, I think, we use an event, send them home an event monitor with a very close surveillance.
Lorena is asking about if the surgery can be difficult in the future after TAVI. I think you have addressed this issue. Probably
we still don't know yet. It's a still open question. Some it depends on the timing of the Explant of the TAVR. We are doing an Explant TAVR registry right now. Vinny, Bapa, and I are leading this on compiling data from all over the world about experience with explanting these transcatheter valves. I think it depends on when the valve is explanted. If it's more than a year or a few years, it can be difficult because of the stent frame can be impregnated into the aortic wall. But we don't have a lot of data on this yet.
Okay, very good. I think unfortunately we are coming to an end because we usually try to keep it about 45 minutes. Maybe two questions. There's one question here. Any difference of difficulty of reduced SAVR S3 and Evolut? I believe I've done some. I think Evolut is tougher because you have that crown upper. It sometimes it's covered with endothelium, while S3 is more in the annulus. What do you think about this, Gilbert?
Yeah, again, the limit. You know, we haven't thankfully had to do many of these. We've done a couple. And my colleagues have done a couple. Again, you're right. It depends on how long the valve has been in place. If it's within a year before the crowns and the frame endothelialized, and it might be easier to remove. But if it's more entrenched, and you might have to be more carefully peel off the frame against the intima or the endothelium to avoid injury to the cardiac structure. So it really depends on case by case.
Okay, and last question, how are you training your fellows with many intervention options available and conventional surgery, each time more reserved for complex cases? And I will add, Gilbert, just to close your very nice presentation, could you give us your vision on how to form, how to train specialist? It may come from interventional cardiology, it may come from surgery, but what do you think, how we can create this new hybrid operator and like yourself, and if you think that this model is a reproducible model?
Well, I think the first and foremost important element of having this training is to have an engaged heart team consisting of interventional cardiologists and surgeons, and both need to embrace each other in terms of being respectful, being collegial, and also being open to both surgical and transcatheter options to manage these patients with complex valve disease, and not just single valve disease, sometimes multiple valve disease. Once you have that relationship, then the next step is the trainee needs to dedicate himself or herself in this training, and we have formed a task force recently looking at potentially a one-year fellowship where a surgeon can gain some catheter and wire skill set, gain some imaging expertise to be able to function as a co-pilot with the interventional cardiology in the cath lab or hybrid OR environment in these structural heart procedures. You know, I think, and that takes some initiatives for the surgical trainee to do that. I have one right now who work with me. We start by training them doing all the complex imaging analysis. So my fellow is very well versed in working out immensely on CT sizing of all the TAVR cases. She is very well versed in looking at echo imaging on mitral clip cases, knowing exactly how to plan these cases. And now she's gaining more catheter and wire skill set, either with the vascular surgery colleagues, the endovascular procedure, or now interventional colleagues, you know, starting with access and closure. So it is a journey, and everyone is a bit different, but I think you have to know the anatomy and the imaging. And the surgical training is a little bit more advantageous because they've been in the operating room, they understand the anatomy relationship better. But even interventional trainee is very important, I think, for them to even go to the operating room to see what an open valve operation looks like, so they understand some of the subtleties and the relationship between anatomy, pathology. And now when they look at a TV screen in 2 dimensions, they can relate to what to do with a catheter approach.
Okay, thank you very much. I think it was a very, very nice presentation and very profitable discussion. And I'd like to thank everybody that participated in this discussion. And thank you very much, Gilbert, for your time, and be safe.
Thank you very much for the invitation. Look forward to working with you.